And so thank you all so much for joining us. My name's Sebastian. I'm here with Julia, another one of the PsychSign region representatives. Today we have Dr. Bhati, who's an interventional psychiatrist in Stanford. He has appointments in both the Department of Psychiatry and the Department of Neurosurgery. He does a lot of great research with regards to the field of interventional psychiatry. It ranges from TCM to other procedural based interventions for patients. It's really at the cutting edge of where psychiatry is moving. So we're so excited to have him. Julia, anything you want to add?
Thank you so much for being here tonight, Dr. Bhati.
Yeah, you're welcome.
Wonderful. So we have received many questions prior to this event from students and residents who have completed forms, questions on a form. So we're going to start off by asking kind of some of the questions we identified from that source. But please, for those who are on, please feel free to unmute yourself, put on your video so we can make this an interactive session. We'll also save kind of a dedicated space at the end for students to ask any questions outstanding that we haven't discussed outside of this. Does that sound okay with you? Great. So I think just before we kind of dive into all the questions, at a high level, can you tell us a little bit more about what interventional psychiatry is and how you became involved in it?
Yeah, sure. But I'm a little confused. Did you want me to give a little presentation or did you want me to just dive into the questions? I didn't know which one you had. I put together a little bit of a presentation that could potentially answer your question.
Oh, that'd be fantastic. Let's do that.
Yeah, I don't want to lecture people though, so I definitely want people to interject and ask any questions along the way, but maybe I can go just really quickly through my presentation. I assume that this was mostly, or if not all, medical students interested in psychiatry potentially?
Yeah, so this is the Psychiatry Student Interest Group Network. So we're a group of medical students across the US, and Sebastian represents kind of the East Coast area and I represent the Midwest area. So we're all from everywhere. But yes, that sounds wonderful. If you're able to share your screen, then that should be able to work. We did get a few questions from residents, but I think it's a predominantly medical student group.
Okay, great. And anyone, please feel free to interject if you have any questions. I have a few slides. Just I wanted to try to kind of tell a story so all of you can kind of understand what my own personal journey towards interventional psychiatry has been, so you can kind of understand what my experience has been like, and also what my sort of appreciation of the field of psychiatry is. So let me share my screen. And I'll try to be fast. I have a few slides, but I wasn't quite sure exactly what to focus on, but I will try to go quickly. Okay.
We can see your screen.
So. Okay, great. All right, cool. So I decided to title this presentation "A Journey into Interventional Psychiatry," and to answer Julia's question, what is interventional psychiatry? I would argue that anything that we do to potentially treat, diagnose a patient is intervention. But as many of you might know, historically, psychiatry is basically a field that entails providing talk therapy and medications. Those are the primary treatments that current day psychiatrists provide. But in the past few years, there's been a growing expansion of what we have to treat patients, including neuromodulatory treatments, pharmacologic treatments, and so forth. And basically, interventional psychiatry emerged in the context of those new treatments as a new field, even though these treatments, I'll show you in a moment, have been around for quite some time. Interventional psychiatry is basically, in my opinion, the application of neuromodulatory treatments to treat psychiatric disorders. Most often those are treatment-resistant psychiatric disorders, so psychiatric disorders that don't respond to conventional psychiatric treatments. But other people will include under interventional psychiatry interventions such as ketamine and the psychedelic interventions as well. So it's a relatively undefined field, but it basically describes a subspecialty of psychiatry where basically there's a larger repertoire of interventions available to help patients. So I thought that maybe I'll start by telling you about my journey and how I became an interventional psychiatrist. I was born in Japan. I'm currently 47 years old. My parents were immigrants. I was an immigrant. My father was a physician who went to medical school in India. He came to the United States to do a residency in general surgery in Texas, and I grew up in Texas, Missouri. I was always interested in the mind and psychology, and went to college at Emory University where I majored in biochemistry. And then after college, I decided I wanted to be an artist because I was very interested in visual perception as a means to sort of, or studying visual perception as a way to understand the world. And I was very interested in exploring how artists exploited visual perception in their efforts to convey beauty and meaning and so forth. So I was very interested in that. And I became convinced when I was in art school that it's really about the brain, right? It's more than just the eye, it's really about the brain. So that's when I started to really get an interest in psychiatry. I applied to medical school. I went to medical school at Louisiana State University in Shreveport, Louisiana. And it was a really wonderful education. And I learned all the basic things that one learns in medical school, and eventually thought about careers in, say, general surgery versus psychiatry. It's a little unusual to have interest in those two fields, but I've always gravitated towards using my hands and doing procedures. But I ultimately chose psychiatry because I preferred the lifestyle that came along with psychiatry. I didn't want to do all the crazy living at the hospital that a lot of surgeons do. So I ended up matching in psychiatry at the University of Pennsylvania. That was a really remarkable place to train as a psychiatry resident. I was able to start to do research as a resident, and I was a resident in 2001 to 2005. And it was a really exciting time to be a resident back then because TMS was being investigated as a potential treatment for depression, and none of these more novel treatments were FDA approved at that time. So I had the opportunity as a resident to get involved in a lot of the early trials looking at TMS, DBS, ketamine analogs, and so forth. So as a resident, I got involved in helping my attendings with these clinical studies that eventually led to these novel treatments in psychiatry. I stayed at the University of Pennsylvania for about 10 years, where I was an assistant professor. I oversaw the ECT, we started a TMS service. I oversaw outpatient psychiatry. I taught the residents and medical students. And then in 2016, I was recruited to come to Stanford to be the section chief for a subsection of interventional psychiatry. It was the first time there had ever been a interventional psychiatry section in the Department of Psychiatry at Stanford. So we established that. And that's where I've been ever since. And it's been a really remarkable experience because during my time, I've been able to collaborate with a lot of people. And I've gotten to a place where I feel like, it's really an exciting time to be in psychiatry and to think about being a psychiatrist. But I have to say, in retrospect, now that I'm in the middle of my career, there are a lot of unanswered questions in psychiatry. There are a lot of problems in psychiatry and unanswered questions which limit our ability to help patients. And I think that opens up a lot of questions and a lot of potential opportunities for future psychiatrists. I feel like I'm already talking too much, so I wanted to ask anyone if they had any questions at this point. All right, so what I'm going to do is I want to just maybe real quickly kind of go through what interventional psychiatry is, because that's why Sebastian asked me to give this talk, was to explain to you sort of what interventional psychiatry was. But I think before we do that, I want to just real briefly talk about the historical context of all of this, and I think that's super important. Two sort of broad questions that I want to just pose to all of you is, one, what is a psychiatric diagnosis? What is a mental illness? what does that even mean? And then the other foil to that is sort of what is a psychiatric treatment? And if one looks back into history, one sees across cultures and across history that there have always been the use of these mind-altering chemicals. They're called psychedelics these days, but if you look back into history, and people argue going all the way back to the period of time where we were cavemen, that there was use of psychedelic compounds to basically intervene in some way, whether or not it was trying to access some sort of God or spiritual power, or help someone who was going through some sort of suffering, or guide someone while they were undergoing some sort of transition in their life. So psychedelics have been around a really long time, and they've been throughout human culture. And it raises the question, what are these drugs good for? If they keep popping up everywhere. So we'll come back to this later, because psychedelics are considered part of interventional psychiatry because they're sort of a one-time intervention. So if you go to the Middle Ages, there was then this thing called trepanation. I don't know if many of you know what trepanation is, but in the medieval ages, they basically would drill holes in people's skulls to try to let the evil spirits leave their head. And that was basically an intervention to treat psychiatric patients back then. It was quite a brutal intervention. A lot of patients died. It was after the Middle Ages where we then entered in a period of time where there was mass institutionalization of patients. That was when there was the birth of the asylum. There were no treatments. There were no psychiatric conditions. There was no psychiatric diagnosis. And people who just were considered unfit for whatever reason, political reasons, social reasons, psychological reasons, psychiatric reasons, were essentially put into asylums. And there were many asylums, primarily all throughout Europe. And then we enter into the 19th and 20th centuries. And these are two psychiatrists who were considered sort of some of the first modern interventional psychiatrists. Both of these individuals won the Nobel Prize in medicine. The person on the left is an Austrian psychiatrist named Julius. I'm not going to try to pronounce his last name, but he won the Nobel Prize in the late 1800s for invention of what was called pyrotherapy, where he would take patients who had syphilis and he would infect them with malaria to treat their neurosyphilis. And the reason why that worked was because malaria is heat sensitive, and malaria causes a recurrent fever. So when you infect people with neurosyphilis with malaria, they get these recurrent fevers, and the syphilis spirochetes lice and it treats the syphilis, but the patients are left infected with malaria. So he was considered probably potentially one of the fathers of modern day intervention psychiatry, and he won a Nobel Prize for that. The person on the right was a fellow named Antonio Moniz. And he was a Portuguese neurologist who won the Nobel Prize for inventing the cerebral angiogram, but he's also famous because he was the inventor of the lobotomy, the prefrontal lobotomy. And as you can see on the right, it's a diagram of what that entailed, and it basically entailed putting a instrument into the brain and basically destroying a lot of the white matter tracts in the brain. And as you might imagine, that had pretty dramatic and bad consequences. But this was, again, before the time there were any real clear psychiatric diagnosis, and there were no psychiatric medications at all. This is a guy named Walter Freeman. He's a little bit more of a modern day interventional psychiatrist, and he was famous in the mid-20th century because he was a psychiatrist who advocated use of the office-based transorbital lobotomy. And this was in the mid-20th century, and he really did a lot of damage to people by doing this procedure. And the reason why I'm sharing all of this to you is because the interventions have been in psychiatry for a very long time. And I think still an unanswered question is, how effective are these interventions? They're quite dramatic interventions, but how effective are they? So we had all of those interventions that were basically interventions that were quite damaging to patients and weren't very effective. And what you're seeing now as medical students, and what I would basically consider modern psychiatry, is basically the pharmacologic era of modern psychiatry. And this is just a brief schematic of the history of psychopharmacology as it pertains to psychiatry. And as you can see here, psychiatric medications have been around for less than 100 years. The first psychiatric drugs that were used were intranasal amphetamines that were given to people before they took airplane flights, before they had pressurized cabins, and they were used to decongest people so they wouldn't get congested on these high altitude airplane flights. And they were basically just given to patients before they boarded airplanes. In 1933, Albert Hofmann synthesized LSD. Its therapeutic potential was investigated soon after he discovered LSD, but as many of you know, psychedelics were outlawed in 1973, and all of that research was buried, which was a shocking finding to me as a psychiatrist, because when I was a resident from 2001 to 2005, I was never taught anything about psychedelics or even the history of psychedelics and how they influence modern day psychopharmacology. So what you basically see in psychiatry in the 19th century is you see in the 20th centuries, in the early 1900s, you don't have any really good treatments. That's when people were institutionalized on a mass scale. And that was when people were first grappling with what exactly is a psychiatric diagnosis. And a lot of people don't realize this, but the origin of psychiatric diagnosis emerged from efforts in the US Census. In 1910, I believe, there were so many people institutionalized in the US, the United States Census felt as though they had to go into these institutions and count people. So they went into these institutions and they started to segregate people into different groups: alcoholics, obsessives, depressives, and so forth. And that was the origin of psychiatric diagnosis. You ask most psychiatrists or psychiatry residents or medical students these days where the word depression and so forth comes from, and most people can't tell you. So I really encourage you to think about that, because I think fundamentally what is one of the greatest challenges in psychiatry, and is something that interventional psychiatry can potentially help solve, is what exactly is a psychiatric disorder? What is a psychiatric condition? So what you saw in the early 1900s was the emergence of psychiatric diagnoses. You saw the use of interventions like the prefrontal lobotomy. In the 1950s, you have, or actually in 1939, you have the first use of electroconvulsive therapy, which was used in catatonic schizophrenic patients in Rome, Italy. And then in the 1950s, that's when the first psychiatric medications were discovered, specifically lithium and chlorpromazine, which is known as thorazine. All of the modern day psychiatric drugs to this day are derivatives of those drugs. And they were primarily used in patients who had really severe psychiatric illnesses because they needed to do something. But a lot of the early psychiatric drugs were so toxic and associated with so many side effects that they weren't really prescribed to that many people. But then in the 1980s, let me just back up a little bit. So you had a lot of research from the discovery of LSD in the 1970s. LSD and the psychedelics were banned. All that research was buried. Emerging from some of that research was the discovery of Prozac. And in the 1980s, you see the FDA approval of Prozac, and then all of a sudden the floodgates open and everyone is prescribed psychiatric medications. You have the discovery of Prozac, you have the invention of Valium, you have all these medications that are relatively safe compared to some of the older medications that just get prescribed to everyone. And during that time, because of the medications, people were deinstitutionalized. ECT was no longer used, and people stopped doing interventions like the neurosurgical interventions because everyone was so excited about the medications. But lo and behold, after 20 to 30 years of medications, the modern day psychiatric medications, we realized that they didn't work very well. So what you're seeing now is us circling back to these prior treatments that we've seen in history before, including psychedelics, interventions, and so forth. But it's a really exciting time because we have better technology, right? And we think we understand the brain a little bit better. So what I want to really quickly do is kind of run through the modern day interventions we have in psychiatry. And this is stuff that typical psychiatrists don't do. Your typical psychiatrist will maybe talk to a patient for a little bit and prescribe a medication. That's what I would say 95% of psychiatrists do. But there's a whole world out there on devices. And the reason why I think devices, well, let me just back up a little bit. The reason why I gravitated towards using devices was because I saw the severe limitations of talk therapy and medications. And if you think about it, medications, well, talk therapy is a very complicated thing. There's a lot going on there. But medications primarily affect neurotransmitters. So they sort of bathe the brain in chemicals and adjust the chemicals in the brain. And they fail to neglect that the brain is a little bit more than just a soup of chemicals. It's a very complex processing organ that consists of circuits and pathways and so forth. And that's where the interventions, I think, are extremely powerful, because they allow us to zero in on very specific areas of the brain and modulate them in various ways in combination with things like psychotherapy and medication. So we can not only better understand the brain, but we can also potentially offer more effective diagnoses and better treatments for our patients. Here is an illustration on this slide of electroconvulsive therapy. Electroconvulsive therapy is the prototypical intervention in psychiatry. It was done in 1939 before any medications were discovered. To this day, it remains the most effective treatment we have in psychiatry. Yet again, 95% of psychiatrists do not prescribe ECT, and that many psychiatrists don't even know how to get their patients ECT. And the reason for that is because in the 1950s, when after ECT was discovered, in the United States, people who were convicted of capital crimes were executed in the electric chair. So people started to associate electric shock with being a criminal, with being punished, with potentially being killed. So there's this tremendous amount of fear and stigma that emerged from the use of ECT. It was believed to be almost a form of torture. But that was very far from the truth. And to this very day, ECT is the only antidepressant that's been shown to reduce mortality. ECT, actually, if you give it to older patients who have depression, reduces older people's risk of mortality who have depression from all causes of mortality. So it's a really remarkable treatment that's extremely underutilized in psychiatry. And part of the reason for that is because for the past several decades, the field of psychiatry has been bought out by the pharmaceutical industry, and you don't see psychiatric residencies teaching residents, or you don't see psychiatric residencies teaching residents how to do ECT or how to do these interventions. We're moving in that direction, but it's something that, you know, the future psychiatrists need to embrace more. So because ECT had such a bad rap, people made efforts to try to develop alternatives to ECT, and TMS, transcranial magnetic stimulation, was one of those. Here you can see on the bottom picture here, this is a guy named Anthony Barker. He's this English neurophysiologist who invented this TMS device, and he's holding it over this subject's motor cortex, and he's able to cause her hand to involuntarily twitch. And he was able to demonstrate that you could actually use this electromagnet and deliver brief pulses of magnetic fields to actually stimulate and modulate the human cortex without causing any perturbation of consciousness or any major side effects in patients. So Anthony Barker was in England at the time, and there just happened to be a psychiatrist named Mark George in England at the same building he was in, and he heard about this machine, and Mark George was a psychiatrist, and Mark George thought that he would use this in psychiatry and apply it to the prefrontal cortex to try to treat depression, because one of the theories of depression is that there's an underactive prefrontal cortex, and maybe this could be one way to modulate that activity and treat depression. And lo and behold, that was the birth of TMS. On the left here is kind of what a modern day psychiatrist's office looks like when it's equipped with TMS. And it's kind of like this sort of boutique psychiatry experience where patients come in, they have a coil placed on their scalp. They don't have to undergo anesthesia. They don't have to get an IV. They don't have to really do anything in particular other than relax. And this magnet is placed on their brain, and they receive repeated stimulation in an effort to treat things like depression and OCD. Yeah, Nick, I see you raised your hand.
Hi, I had a very quick question regarding the transcranial magnetic stimulation. Is the effect that the magnetic pulse has on the brain, is that excitatory or inhibitory within the individual neurons it's affecting?
it depends on how you administer it. That's one of the neat things about TMS is that depending on how you administer the magnetic field, you can cause modulation of the brain activity in all kinds of different ways. You can excite it, you can inhibit it, you can do all kinds of things. I'll talk more about that in a bit.
Oh, wow. Thank you.
Yeah, Amir?
Hi there, Dr. Bhati. I'm a third-year psychiatry resident, and sometimes we were reading some papers about, I know you talked about antidepressants. I know that like in some studies we're starting to show that maybe like for mild to moderate depression, some of our SSRIs might not be as effective in comparison. I was wondering if you could, I'm curious about your opinion on that or your experience.
Yeah, that is absolutely correct. And we'll talk a little bit more about that because I think what that's related to is the placebo effect.
Thank you.
And we're going to talk about that at the very end.
It looks like we also have a question in the chat from Agnes. It says, alluding to your comment on the pharmaceutical predominance in training, what is your thought on using these interventional forms of treatment earlier on in treatment? So I think maybe we can get to this after.
That is a great idea. We need to do more of that in psychiatry, but the problem is most psychiatrists don't know how to get patients these treatments. But that is a great idea. You know, one of the really nice things about these interventions is that they're potentially short-lived treatments. You know, these don't result in patients having to get treatment for the rest of their life, like with a lot of medications. So good idea. Okay, let me keep going. I want to try to get through this really quickly. And again, feel free to interrupt. Actually, these are great questions. So just to kind of tell you a little bit about TMS, and I don't want this to be a technical or a detailed talk, but TMS is really fascinating. And one of the cool things about TMS is that if you change the geometry of the coil, basically the way TMS works is that it's based on Faraday's law. So if you have a fluxing magnetic field through space and time, it creates a perpendicular electric current. So it's a way to non-invasively create electric current in the brain without delivering electric current. You just pulse a magnetic field which travels painlessly through the skull and scalp, and you can actually alter the electrical currents in the brain. And if you alter the shapes of the coil, you can create different patterns of magnetic fields and electric current flow. And that's just an example of all the different things you can potentially do with TMS. You can change the coil geometry, the architecture of the coils to alter these magnetic fields. And you know, alluding to some of the questions that were asked earlier, this is a powerful technique to intervene with the brain. And TMS is actually the most studied form of brain stimulation, and neuroscientists use it extensively because it's such a safe and interesting way to modulate the brain. Here is one way that we can cause excitation or inhibition of the brain, and that's by delivering different patterns of TMS. So depending on whether or not you're delivering it like this at 10 hertz at a relatively high frequency, that leads to cortical excitability. If you deliver TMS at 1 hertz, that results in cortical inhibition and depression. If you do things like intermittent theta burst, it's basically delivering stimulation at a theta burst frequency similar to what you see in the brain during learning and memory. And that's thought to be associated, that's thought to then be able to result in learning and memory changes, neuroplastic changes associated with TMS. So there are a lot of things you can do with TMS as illustrated here. Some other interventions that are probably less common use but are also interesting include things like vagus nerve stimulation. I don't know if many of you have heard of vagus nerve stimulation, but vagus nerve stimulation is a neurosurgical intervention for epilepsy. It's FDA approved for epilepsy, and it's FDA approved for treatment-resistant depression. But very few patients get this treatment for their depression because insurance companies refuse to pay for it, even though it has FDA approval. What vagus nerve stimulation essentially entails is the implantation of a pulse generator. So this is a battery and a pulse generator implanted subcutaneously above in the pectoral area, and it's attached to an electrode that's wrapped around the left vagus nerve that is thought to then stimulate afferent nerve fibers that go into some of the neuronal cell bodies in the lower brain and potentially alter things like monoaminergic functions and so forth. It also has an anticonvulsant effect. That's why it's approved for epilepsy. And we use anticonvulsants extensively in treatment of psychiatric disorders. There's currently a very large multi-center study underway in the United States to try to get insurance companies to pay for this. So by the time you become psychiatrists, if this study is successful, this is another intervention you'll potentially be treating to your patients. And there's a lot of interest these days in the vagus nerve. It's a very sort of trendy thing. And the reason why is because the vagus nerve is involved in all kinds of interesting things like relaxation, meditation, GI function, and so forth, which are things that we very often see are used for treatments in psychiatric disorders. Another treatment that's very oftentimes talked about in psychiatry is a treatment called deep brain stimulation. Deep brain stimulation is extensively used for treatment of movement disorders, primarily Parkinson's disease. But there are major efforts currently underway to try to get deep brain stimulation as a treatment for treatment-resistant depression and severe OCD. And the interesting thing about DBS is that DBS in its current form essentially targets the same white matter tracts that were targeted by lobotomies when they were done in their crude and blunt fashion. We just have the technology now that enables us to basically target those same areas of the brain without being so destructive. And DBS is actually considered a reversible yet invasive form of brain stimulation. It requires neurosurgery, but you can put these electrodes deep into the brain and then remove them without any major complications to patients. And just like VNS, it involves a pulse generator implanted in the chest, only it's connected to electrodes that go deep into the brain rather than to a cranial nerve. Here's a video I wanted to share with all of you because, you know, as a psychiatrist, you know, I had a lot of questions about what exactly are we doing here? You know, what exactly is depression? You know, how can we be so bold to say that something like DBS in one area of the brain can treat depression? But then I treated this patient. This patient has a deep brain stimulation. She has deep brain stimulation electrodes in her bilateral ventral striatum. So that's the area of the brain that's responsible for pleasure and reward. And I'm about to turn on the DBS for the first time in this patient. And I want to show you what that was like. It was a really cool experience.
We're going to do deep brain stimulation today, and I want to let you know that
pay attention to her face, her affect.
What we're trying to do today is we're trying to improve your mood, and you may notice a whole host of things, including twitches in your face. You may
very depressed right now.
Palpitations,
downward,
odd
downward
smells, or
edges of her mouth, or
so
affect
like that happens,
kind of restricted and flat.
Are you ready for the stimulation for the time? Yes. Okay, so here we go.
She's holding a telemetry device over the pulse generator so I can program it and turn it on.
So we're going to try something. I'm going to start it right now and tell me if you experience any side effects, okay?
So literally at the press of a button, I could make this patient smile. And she has half of a smile. You can only see only the right side of her face is smiling.
Just, yeah, I can control it, but I mean, it happens, but then I think.
Her affect has changed. Pay attention to her affect because I'm going to turn it off now.
We'll see what happens.
Yeah. Yeah. Isn't that amazing? So I don't know if depression exists. I don't know if depression is in one place in the brain, but there's something going on here. And I think it's worth exploring. So DBS typically works by just stimulating chronically and constantly, but we have better technology now. We now can do what's called closed loop stimulation, where basically we have the ability to record brain activity and then stimulate in response to specific brain signals. And there is an FDA-approved device right now that's manufactured by a company called NeuroPace. It's FDA-approved for treatment of epilepsy. And it basically involves an implanted DBS device that's also connected to a recording electrode. So what it's able to do is it's able to monitor seizure activity, and when it detects increases in seizure activity, like you can see in this heat map here with this increased frequency of cortical signal, it then stimulates and then it suppresses that seizure activity. So there's a lot of interest in applying this technology to psychiatric patients. And here's just an example of how it works. I'll just show you this video real quick of how it works. But it basically sits in a case in the brain. It's both a recording device and a stimulating device. It can connect to telemetry to a laptop. Here you have a depth electrode and a surface electrode. They're both recording brain activity. They're just waiting for a specific signal. It detects the signal and then it stimulates that area. And it just keeps doing that over and over and over again. So it's not just chronically stimulating like DBS works, but it actually can detect, stimulate in response to specific signals. This is really great because it provides us the option to potentially target these conditions that have sort of intermittent symptom presentations. And one of the things that we're very interested in is using this type of technology to treat impulse-related disorders or fear-based disorders, because fear kind of comes on suddenly and then goes away. Impulsivity kind of comes on suddenly and goes away. This is my colleague, Casey Halper. He's a neurosurgeon. So he basically was very interested in potentially using this technology to treat patients that have binge eating. So he basically implanted responsive neurostimulators into 2 patients with obesity and binge eating. And we were able to demonstrate that we could actually eliminate the binge eating pattern behavior in these 2 patients. It's only 2 patients, so you can't really make any large conclusions from that. But it was published in Nature Medicine and it was written up in the New York Times. So it was getting some interesting press and just another example of how these technologies are being investigated. There is another group who's looking at this technology for use in depression. And they're at UCSF currently, and they've gotten quite a lot of press for their work. Other new technologies that are used in interventional psychiatry include focused ultrasound. Ultrasound is really fantastic because it is a non-invasive way to modulate deep brain structures. So it's a way to basically do surgery on the brain without doing a craniotomy. And this is how it works. You basically have a bunch of ultrasound transducers, very similar to what you have in diagnostic ultrasound, fetal ultrasound, and you have an ultrasound transducer array. And if you're able to align the phase of ultrasound in specific patterns, you're able to basically create a thermal lesion deep in the brain. So you can essentially do deep neurosurgery without having to open up the skull. And people are very interested in using this technology and have done trials looking at OCD and depression, and have basically essentially replicated, or they're essentially doing modern day versions of lobotomies without opening people's heads, because they're targeting all the same areas of the brain that were originally targeted by the lobotomies. And then going even one step further, I have a colleague here at Stanford who's looking into developing nanoparticles that are filled with drugs that you can inject into a human and then use ultrasound to cause specific, anatomically specific release of drugs within the brain and body. So we might in the future with ultrasound have the potential to actually release drugs only into specific areas of the body without bathing the entire drugs in chemicals like we currently do in conventional psychiatry. I'm going to skip this stuff, but my point in putting all this stuff in there is that as a psychiatrist, you have to be knowledgeable about this area. And the reason why is because your patients will be knowledgeable about this stuff. There is a growing community of DIY brain stimulation people out there. And there are also TMS machines that are being sold on places like eBay. So your patients are going to inquire about these treatments, and they're also going to just develop their own treatments. These types of brain stimulation are oftentimes very popular amongst people like gamers who are looking to improve their playing. So people are very interested in this, and I think it's something that psychiatry needs to embrace. And then I'm almost finished, by the way, but I wanted to kind of wrap up with psychedelics because kind of going back to the beginning, sorry about the dogs, but I think psychedelics are very powerful tools, very similar to the device-based interventions, because they offer us ways to probe consciousness. They offer us ways to probe the brain. And when we can use these tools to better understand the brain, I think that just has this sort of iterative effect where we can have a better understanding and develop better treatments. And I want to just bring to all of your attention this article that was published this just a couple of weeks ago in the New England Journal of Psychiatry, where they showed in a large multi-center study that psilocybin, one dose of psilocybin was effective for treatment-resistant depression. So this stuff is coming down the pipeline. And there was another study that showed that MDMA was helpful for treatment of PTSD. So we'll also probably see that get FDA approval as well. And the reason why these sorts of interventions fall under the umbrella of interventional psychiatry is because they're sort of these one-time or time-limited interventions that are sort of intensive and require sort of more intensive interaction rather than taking a pill or doing talk therapy. And then lastly, I just wanted to just mention the placebo effect. And this is one of the things that oftentimes makes me think in psychiatry. You see the placebo effect in a lot of places. You see it with medications, with neurosurgical interventions. But I think the placebo effect is kind of like psychedelics because whatever they do, it can be examined neuroscientifically. You know, we can look at people and get an idea of what in their brain is going on that makes them have a placebo effect. And we can look in a person's brain when they're taking a psychedelic and see what causes a change in obsessive thinking or a change in mood and so forth. So these are very powerful interventions that I think can kind of help us just more refine what we're doing and just, you know, advance the field of psychiatry. So thanks for letting me talk. I just wanted to end by saying that we have a fellowship at Stanford. And I know that all of you are medical students. I know there are a few residents there. So any of you residents who are interested in interventional psychiatry, we have a fellowship and we would love for you to apply. So I just want to kind of put that out there. My email is at the bottom if any of you have questions, but at this point, maybe I'll stop sharing my screen. And if anyone has any questions or anything like that, I would be glad to answer.
I think you
sorry,
have
I'm sorry I'm not keeping up with the chat. I just can't.
oh no, all good. I think Julia's gonna go ahead and begin the Q&A. If you had seen our faces when you showed that video of the intervention and how immediately it worked, you would have been laughing. Julia, do you wanna take it away with some of those chat questions?
Sure. So we can get to the questions in the chat first, and then as they come, please, continue to post your questions. Otherwise, we'll go to the questions from the form as well. But we have about 15 minutes or so. So thank you so much. That was so fascinating. And personally, I really thought it was kind of limited to the TMS, DBS area. It's amazing to learn more about kind of all of the other options and the potential that they all have. So thank you for sharing. So one question, you can see in the chat as well, but I will read them out for the sake of this recording. So Veronica was asking about how accessible these treatments are for an insurance perspective. Are these covered yet? I know you mentioned that the vagus nerve is not, but how about other interventions you spoke about?
Yeah, clinically, that's a very challenging thing. It's another barrier to providing these treatments to our patients. And that's also why you more often see these treatments available in academic medical centers and in research studies. But these days, ECT is pretty much covered by all insurance. TMS is covered by most insurance, and the others just depend on the type of insurance. And we still live in a country where we have lots of different types of insurance depending on what you can afford.
Yes. Okay, we have a question. I'm definitely going to mispronounce your name. I'm so sorry. Unye asked, I have heard that there are associations with depression after long-term DBS treatment in Parkinson's patients. Is there any evidence supporting this? And would that make DBS more of an acute treatment than a continuous one? So kind of talking about the timeline for these treatments.
Yeah, no, that's a very good question. A lot of people have looked into this. So the depression and cognitive symptoms of Parkinson's aren't typically treated by DBS used in Parkinson's disease. The DBS used in Parkinson's disease tends to focus on the tremor and really helps the tremor very much, but it doesn't seem to help the depression or the cognitive symptoms very much. So it's seen as a sort of residual symptom of Parkinson's disease that just isn't responsive to the treatment DBS.
Okay. Thank you. Is this an okay way to do this? Just kind of
Yeah.
go online?
Yeah,
Okay.
no, that's totally fine. But I was wondering, do we want to just give people the opportunity to ask their own questions? So it's
Yeah,
not
I
the
love
two of
that.
us talking and other people can talk as well.
If you're willing to unmute, I can kind of call you to unmute. So, Stuti, would you like to share your question?
Yes, thank you so much for talking to us today. I just had a question about DBS. For patients who do experience the symptoms of depression and epilepsy and have both diagnoses, would you see a decrease in symptoms for both conditions if you were to implement this procedure?
DBS in patients that have epilepsy and depression?
Oh, yes.
Yeah, well, yeah, that's a really complicated thing. Most patients with epilepsy have depression, and it's a very complicated depression for a number of factors. And I'm not aware off the top of my head if anyone has used DBS to treat both epilepsy and depression. DBS is FDA approved for treatment of epilepsy, but it's not a very common treatment. I hope that answered your question.
That's it. Thank you.
Okay.
Yeah, so I think maybe we can just go down the line. So I guess next is Amy, and feel free to just like unmute yourself. So yeah, we don't have to kind of do the line, if you will.
And feel free to interrupt too if other people have follow-up questions or want to discuss it.
Yeah, I was just curious. Thank you again for this talk. In terms of these procedures that you were mentioning, are these done by neurosurgeons or is this like a fellowship trained? Do psychiatrists do that as well? Yeah.
Yeah, no, that's a great question. I usually like to separate interventions into the invasive and non-invasive interventions. Psychiatrists can do non-invasive interventions. So that includes ECT, TMS, anything that requires cutting, typically a surgeon will do. Although there are surgeons who are very much like psychiatrists these days. Functional neurosurgeons are very interested in the world of psychiatry, but there aren't a lot of those neurosurgeons around.
Thank you.
Interesting, because you wouldn't think that neurosurgeons and psychiatrists would be the closest of colleagues in a hospital, but we are seeing that, with this particular area, which is great.
Exactly.
Nicholas, I saw you had your hand raised. Did you want to ask your question?
Yes. Sorry, my question was similar to the one that was just asked. I mean, I guess as a follow-up for the more invasive procedures, I guess what is the process like interacting with the neurosurgeons? Do you sort of refer the patients out for these treatments to neurosurgeons who specialize in them? Or, what level of contact do you have with them in planning these treatments?
Yeah, it really depends on the neurosurgeons, but as all of you know, most surgeons like to just kind of go in, do their thing, and then get out. So what you'll typically see is most of the neurosurgeons that are doing these psychiatric interventions are at academic medical centers, and you can put in a referral for these neurosurgeons to see these patients and to do these treatments. And typically the neurosurgeon will kind of take over at that point and make the assessments and talk to the insurance companies and so forth. But after the surgery is over and the real hard work begins, that's where the interventional psychiatrists then take over and do things like change the programming settings and do different types of testing to try to get these patients better. But generally, it's just sort of a refer to a neurosurgeon, they kind of take care of it, and then they come back to you. For some of these devices, especially the DBS devices, the companies will actually be very involved because these devices are very complicated to use and involve software and tablets and interfaces that the company has resources to provide technical support for. So you'll interface also with a lot of these device companies.
Abhinav, I'm so sorry. I saw you come off mute. Did you want to ask your question?
Yeah, hi. I'm a neurosurgery resident from AIMS. It's in India. Recently, it's a great program here in neurosurgery. Even many US surveys ranked it in top 100 this year. So our department was really happy about that. So yeah, what I wanted to ask is, can neurosurgeons apply to the interventional psychiatry fellowship in Stanford? And the main question was that the vision for future, can interventional neuropsychiatry change the treatment timelines which in psychiatry exist these days as months to years to something like weeks to days? And not just for treatment resistant, can they replace the pharmacotherapeutics itself? Can we, like, it not a second line, something which comes after a treatment failure, but we start with something like TMS, like if we know that it works and it demonstrates results, even something like DBS, like why not start with TMS? Why start with medicines? So that was the question. Thank you.
Yeah, yeah. We do encourage people to be a part of our fellowship from all kinds of different specialties, including neurosurgery. It's a non-ACGME accredited fellowship, so we're not restricted to just psychiatry residents, although it is primarily psychiatry. I hear what you're saying about potentially using DBS, but the problem with DBS, from my perspective, when it comes to providing it more broadly, is that it's very difficult to provide DBS to a lot of people. And there are a lot of very depressed patients out there, and there are only so many surgeons. So one of the main limiting factors with using DBS as a clinical intervention is the significant amount of resources and specialty training needed in order to even get the treatment. But some neurosurgeons do talk about temporarily and rapidly using these devices. Maybe putting a device in, having it do its job, and then removing the device. But we're very far from being able to do that in psychiatry. The actual thinking these days is that the neurosurgical interventions, including DBS and capsulotomy, the older neurosurgical psychiatric interventions, typically will take months to years to show their final effects. So it might be that the neurosurgical interventions are not rapidly acting treatments. Sorry about my dog.
Miriam, did you want to ask your question?
Hi, Dr. Bhati. I'm Miriam Nagvi. I'm a third-year psychiatry resident at Riverside University Health System. It's in Southern California, but I'm a NGMS alum, so that's how I heard about the lecture. So, our clinic was actually trying to open up a TMS lab. Do you have any tips or advice on how to go about opening up the TMS, clinic, because we're in the process of applying for funding and whatnot?
That's great. I really admire that you're involved in that as a psychiatry resident. What I would recommend is I would reach out to the device manufacturers and I would shop around and learn about the different devices. And then once you settle on a device that seems interesting to you, then discuss with that person what you need to basically get going with that device. On the sort of clinical side, you'll need to work with your insurance and billing people, but it's relatively straightforward. In most cases, patients go through a consultation to see if they're appropriate for TMS. They're referred to us for TMS. They get a consultation. Most patients are good for TMS. And then we have a medical assistant basically get prior approval through an insurance company. And then we have those patients come in Monday through Friday for 6 weeks. So we basically have kind of like a mill where patients come in, get their treatment and leave. And then they go back to their primary psychiatrist after they're done. But I would talk to the device manufacturers and just talk to the administrators in your department.
Okay, definitely. Thank you for the input. And then I also had a question that I dropped in the chat about the fellowship that you mentioned. Is it for residents that have already graduated, like completed 4 years of training, or is it like a fast track option?
It's a relatively young fellowship. We have our second fellow currently, and we've been taking fellows who are PGY5s, essentially, who finished their 4 years of psychiatric residency. We would take someone as a PGY4, but I don't know what my department would say, but I would be open to it.
Got it. Okay. Yeah, good to know. Thank you.
Daniel?
Yeah, hi. Hi, Dr. Bhati. Thanks for giving this talk. I was just curious, so do you have any thoughts on like Neuralink kind of being a more permanent implantable device in the brain, developed by Elon Musk? But I think so far he's like primarily indicated it for epilepsy, but he has mentioned that it might be used for like anxiety and depression in the future. Just general thoughts on that. Maybe do you see that kind of becoming a larger domain in interventional psychiatry or neurology as we move forward? And then the second question is just like regarding these devices, what kind of typically really pushes insurance companies to kind of be able to reimburse this? Is it just kind of the FDA approving it through clinical trials, or is there something else like other external factor behind that?
Okay, let me just see if I can remember that. So Neuralink is really fascinating. I think it is the future. I told you about the company NeuroPace. There are all of these companies that are out there that are working on this incredible technology that basically links our brain activity to smartphones, computers, and the internet. And one of the things that kind of blows my mind about all of this, I experienced it working with some of these NeuroPace patients. I kind of compare Neuralink and NeuroPace. I think they're kind of similar in a way. But with the NeuroPace patients, they have like constant 24/7 recording of their brain activity. And they use a telemetry device to download all that activity to a laptop. And that laptop then beams all of that brain activity to the cloud. And then as a clinician, I'm able to log in to a website and look at all of that brain activity. I can tell when the person's awake, when they're sleeping, when they drink coffee, when they're having seizures. It's a brave new world. And an area that is of growing importance is neuroethics. And it's a very interesting field from an ethical perspective, because and I experienced this personally, when you put something in someone's body, it becomes them. And you can't argue with them about taking it out. And it becomes, there are all these sorts of philosophical questions that then start to emerge. But I think, Elon Musk is a bit of a crazy guy, but he's definitely a future thinker. And I think it is definitely the future. And we have to sort of think about that, especially what our role as psychiatrists might be in all of that. But what was the second question you asked? I forgot what you asked. You asked.
No, thanks. That was a great answer.
Okay.
It was just generally just like what kind of helps push insurance companies to reimburse devices? Is it just clinical trials approval?
Yeah, that's a complicated question. It's got a complicated answer, but to be sort of succinct, it's basically Medicare. So Medicare is basically the standard for all insurance companies. So if you have Medicare approve and pay for something, then most insurance companies will follow that. Otherwise, it's just a matter of haggling with individual insurance companies. And there's good insurance and there's bad insurance. But if it's something that requires, like, if it's like DBS, for example, you're referring a patient with DBS, honestly, just leave it up to the neurosurgeons. Because the neurosurgeons have a whole team of people who can sort through that stuff. And neurosurgeons are also, they have a lot of financial resources because they make a lot of money for the hospital. So neurosurgeons can typically do things that you might not think are possible.
Thank you so much, Dr. Bhati. We really want to be mindful of your time, and so if we could just zoom out and get a long-term perspective for our students, how do you recommend that students get more involved with the field? Specifically, is it reasonable for students to be looking at residency programs that specifically train their resident physicians in interventional psychiatry? If not, what are other ways that they can connect with professionals like you in the field? And I think that would be our last question. Thank you again.
Yeah, no, thank you. That's an important question. I would ask about it when you're doing interviews for residencies, and at a minimum, I would ask about training in ECT. ECT is an ACGME requirement for resident training, yet most residents don't get any training in ECT. If a place offers ECT, then you know that they're open to doing these types of things, and I would encourage you to do that. Just as a word of advice, you have to be really thoughtful and careful about selecting psychiatry residencies, because psychiatry used to kind of be like a cult. There are different sorts of schools of thought in psychiatry, and there still are psychiatric residencies out there. They're just kind of one type of psychiatric residency that, say, focuses on Freudian psychoanalysis or, one other type of thinking. And you want a residency that's broad, and then exposes you to more than just prescribing pills and talking to patients. And if you're interested in connecting with people who are interventional psychiatrists, I encourage you to go to the conferences. There's the ISEN conference where a lot of the ECT doctors go. Many of the doctors who do ECT do the other interventions. There's also the meeting of the Society of Biological Psychiatry, which has a lot of people who are doing research and clinical work in interventions, and network, just get to know people. That's how it works. The more specialized you get, the smaller the community becomes, and you have to just reach out to people. And most people are open to hearing from people, because especially for interventions, this is kind of the reason why we have the fellowship at Stanford. We need more doctors who can provide these treatments. So we want to provide we want to provide the training to as many people as possible. We would love to hear from any of you if you were interested in exploring this field more.
That's wonderful. Thank you so much, Dr. Bhati. We kept a hold of over 40 medical students during our hour talk. So we're really happy to have you here. And we want to thank all of our students for coming out. Julia, anything else to say before we close?
Thank you so much for your time and for your insight. And I am speaking for all of us. We all learned a lot. So thank you.
Right. It's awesome that everyone's